Let's dive right into this explainer. Welcome to a rigorous, university-style deep dive into the precise physiological mechanisms and emergency management of potassium disorders. We are absolutely not holding back today. We're going to execute a lossless, high-density analysis of potassium balance, moving all the way from the molecular mechanics of the cell membrane straight through to bedside emergency resuscitation. If you're looking to truly master the fluid dynamics and those lethal arrhythmias associated with extracellular and intracellular shifting, well, you are in exactly the right place.
Here's a quick look at our 6-part academic roadmap. We'll start with cellular physiology and renal handling, then thoroughly map out the workup, the electrocardiographic evolution, and the exact emergency treatments for both hypokalemia and hyperkalemia. Let's get to it.
Part 1. Cellular physiology and membrane potential.
We have to begin at the absolute foundation. Potassium is overwhelmingly an intracellular cation. We're talking 95 to 98% of it safely locked away inside your cells, predominantly residing in muscle tissue. To quantify that, the mathematical constant for approximating total body potassium is 50 milliequivalents per kilogram. Now, why does this intracellular dominance actually matter clinically? Well, think about it. If you infuse a patient with 40 milliequivalents of potassium, it only raises their serum level by roughly 0.5 milliequivalents per liter. The vast majority of that infusion immediately shifts right into the intracellular fluid compartment. What you're measuring in the blood is completely dictated by this intracellular-extracellular distribution.
And there is a very precise mechanism driving that distribution, the basolateral sodium-potassium ATPs. This cellular pump continuously extrudes 3 sodium ions in exchange for 2 potassium ions, which establishes that intense intracellular dominance we just talked about. What's fascinating is that in highly trained athletes, this pump is physiologically upregulated, driving even greater intracellular potassium uptake. But conversely, this exact same pump is competitively inhibited by digoxin. Because potassium and digoxin compete at the very same binding site, severe digoxin toxicity can therapeutically precipitate profound hyperkalemia.
This brilliantly illustrates the lethal stakes of that extracellular to intracellular ratio. This ratio literally dictates the resting membrane potential. In hypokalemia, the increased gradient causes potassium to exit the cell. That hyperpolarizes the membrane, which decreases tissue excitability and leads to classic clinical presentations like flaccid quadriparesis or a paralytic ileus. Juxtapose that with hyperkalemia, where potassium is retained. This shifts the resting membrane potential to a less negative state, increasing tissue excitability. And that is precisely why hyperkalemia triggers lethal ventricular arrhythmias.
Section 2. Renal handling and aldosterone.
Moving from the cell to the nephron, we need to lock in a cardinal diagnostic heuristic. Severe hypokalemia is renal loss, and severe hyperkalemia is renal failure unless proven otherwise. Your kidneys are responsible for 90 to 95% of potassium excretion, and the regulatory command center for all of this is the aldosterone-sensitive distal nephron. Aldosterone targets the principal cell, inducing proteins that activate the epithelial sodium channel, or ENaC. This drives sodium and water retention. Electronegativity then steps in, forcing potassium secretion right into the lumen via the ROM-K channel. This whole process is tightly linked to hydrogen ion excretion via intercalated cells. Understanding this specific triad, salt retention, potassium excretion, and hydrogen excretion, perfectly explains why hyperaldosteronism, like Conn's syndrome, presents with the classic triad of hypertension, hypokalemia, and metabolic alkalosis.
We also see this physiological handling play out clearly when we contrast our dominant diuretics. Furosemide blocks the sodium-potassium 2-chloride cotransporter in the thick ascending limb, which causes significant calcium excretion but relatively less hypokalemia. Thiazides, on the other hand, cause massive downstream electrochemical shifts in the distal tubule. Because of that downstream shift, thiazides are notoriously worse offenders for driving severe potassium wasting alongside concurrent hyponatremia.
Section 3. Hypokalemia, etiology, and workup.
Let's anchor this diagnostic pathway with a classic clinical scenario. Imagine a 34-year-old male with acute bilateral areflexic flaccid quadriparesis, but it's sparing the cranial nerves. When a patient presents with intermittent profound weakness like that, it demands an immediate potassium workup. Now, once hypokalemia is confirmed, what's your very first diagnostic check? It absolutely must be magnesium. Magnesium is the easiest reversible cause to rule out. Hypomagnesemia structurally makes the ROM-K channel in the distal nephron leaky, and that leakiness causes relentless, uncorrectable potassium wasting. Some classic culprits that precipitate this leaky ROMK phenomenon include aminoglycosides, cisplatin, and proton pump inhibitors.
Now, if the magnesium is perfectly normal, you check urine potassium. A spot urine potassium above 15 milliequivalents per liter confirms it's a renal loss. From there, the next indispensable test is an arterial blood gas. The ABG is incredibly efficient at splitting renal potassium wasting into precise pathological buckets. If there's acidosis, you are dealing with renal tubular acidosis. If there's alkalosis, combined with normal or low blood pressure, you're looking at Bartter or Gittleman syndromes. But if you see alkalosis combined with high blood pressure, you have to move immediately to endocrine etiologies, things like Conn syndrome, Cushing's, Little syndrome, apparent mineralocorticoid excess, or glucocorticoid remediable aldosteronism.
But what if the kidneys aren't wasting it? Well, then we have to consider non-renal blood-to-cell shift etiologies. And the list here is crucial. Insulin, especially during DKA treatment, beta-2 agonists like salbutamol, alkalosis, alpha agonists, barium intoxication, theophylline, and chloroquine. I should also point out one extremely rare gastrointestinal exception, VIPoma. This causes WDHA syndrome, which is marked by watery diarrhea and hypokalemia, but presents with a normal anion gap metabolic acidosis.
Section 4. Hypokalemia, ECG, and treatment.
Transitioning from diagnostic algorithms to immediate bedside concerns, you must be intimately familiar with the rigid timeline of ECG degradation as serum potassium plummets. It's a precise evolution. As potassium drops from 3.5 down to 3.0, you start seeing low T-wave amplitude. Drop below 3.0 and U waves appear. A significant U wave is strictly defined as being taller than or opposite in direction to the T wave. Once you drop below 2.5, you've hit critical danger. ST sagging, severe QT or QU prolongation, and the classic, highly lethal polymorphic ventricular tachycardia known as torsade de pointes.
For severe cases, we follow an exact numerical protocol for IV replacement. Step 1. 2 ampules of potassium chloride, which equals 40 milliequivalents. Step 2. Dilute that in 200 milliliters of normal saline. Step 3. Infuse at a maximum safe rate of 20 milliequivalents per hour. Step 4. Cap your daily limit at 160 milliequivalents. Remember that physiological constant we covered earlier? That 160 milliequivalent maximum will safely achieve an approximate 2 milliequivalent per liter rise in the total serum concentration.
When it comes to chronic management, particularly in renal tubular acidosis, standard tablets just are not sufficient. You need potassium citrate syrup. Just 35 milliliters a day provides 70 milliequivalents of potassium and 70 milliequivalents of bicarbonate equivalent. This simultaneously corrects both the deficit and the acidosis. Now, for proximal RTA, which requires immense daily alkali, sometimes up to 10 to 15 milliequivalents per kilogram, potassium citrate alone isn't enough. In those cases, we supplement the remainder with Scholl solution, which is a specialized sodium citrate and citric acid mixture.
Section 5. Hyperkalemia, pathogenesis, and hypoaldosteronism.
Let's pivot to the opposite extreme. Remember our rule, hyperkalemia is fundamentally renal failure unless proven otherwise. If you have a chronic kidney disease patient on a Monday-Thursday dialysis schedule who presents on a Monday morning with vague symptoms like palpitations or severe tiredness, they require an immediate ECG, no exceptions. But what if renal failure is completely absent or maybe just disproportionate to the potassium level? Then you are dealing with an aldosterone insufficiency, categorized broadly as RTA type 4. We divide this massive differential into 3 specific buckets. First, hyporeninemic hypoaldosteronism, driven mainly by diabetes impairing prorenin conversion, along with NSAIDs and beta blockers. Second, hyperreninemic hypoaldosteronism, where renin is high but aldosterone is blocked by ACE inhibitors, ARBs, or heparin. And finally, pseudohypoaldosteronism, where the hormone is physically present but blocked right at the receptor level by drugs like spironolactone, structural issues like reflux and obstruction, or calcineurin inhibitor-induced tubulointerstitial injury.
To explicitly diagnose this, academic exams absolutely love the transtubular potassium gradient, or TTKG. It mathematically calculates the potassium gradient across the tubule. In hyperkalemia, a normal response should be above 8, so a TTKG less than 8 confirms an aldosterone issue. The next step is to administer a 0.05 milligram fludrocortisone dose. If the TTKG rises, you've proven true hypoaldosteronism. If it fails to rise, it perfectly distinguishes a pseudo-hypoaldosteronism receptor defect. While this tool is clinically obsolete on the modern wards, it is absolutely crucial for academic mastery.
Section 6. Hyperkalemia, Emergency Medical Management.
When a patient's resting membrane potential hits end-stage excitability, immediate sequential intervention is a literal matter of life and death. Look at this terrifying progression towards sudden cardiac death. At 6 to 7 milliequivalents, you see those classic, tall, peaked T waves. From 7 to 8, P wave flattening and PR prolongation occur. From 8 to 9, the QRS widens dramatically. And once you cross 9, you reach the terminal sine wave pattern. I want to make this explicitly clear. Stabilizing this cardiac rhythm immediately supersedes any neuromuscular symptoms.
The treatment follows a strict 3-step life-saving algorithm. Step 1, stabilize the myocardium using calcium gluconate. This is absolutely vital. Calcium gluconate raises the action potential threshold, functionally antagonizing the excitability. But we must make it categorically clear. It does absolutely nothing to lower total body potassium. Step 2, shift potassium intracellularly using insulin dextrose and albuterol. Step 3, definitive elimination, typically via emergent hemodialysis in a CKD patient.
Let's contrast the pharmacology of those two bridging therapies we just mentioned. Insulin dextrose, which is 10 units of insulin and 500 milliliters of 10% dextrose infused over an hour, drops serum potassium by roughly 1 milliequivalent, peaking at exactly 60 minutes. Albuterol nebulization, requiring a massive dose of 10 to 20 milligrams, peaks slightly later, around 60 to 90 minutes. So they have distinct onset times. But what's critical is that both demand strict follow-up dextrose infusions to prevent catastrophic hypoglycemia while you are preparing the patient for dialysis.
I'm going to leave you with this final provocative thought. 98% of a patient's potassium is hidden away inside their cells. Our entire neuromuscular resting potential relies entirely on precariously balancing just that remaining 2% in the extracellular fluid. When you fully recognize that immense mathematical fragility, you realize just how easily a minor physiological disruption, a dose of thiazide, an episode of diabetic ketoacidosis, a missed Monday dialysis, might push your next patient right over the edge. Respect the potassium gradient on the wards. Thank you for joining me for this explainer. Keep learning, keep pushing the boundaries of your clinical physiology, and I'll see you in the next one.